How are you, Noura?
Hello, Dr. Nadia.
So, uh, are you ready for the presentation?
Yes,
Thank you so much for your help.
you are welcome. Thank you.
What's that? Hello. Just setting the recording and then we can start in a minute or two.
Okay, would you let me know?
All right. Hello, everyone. Welcome to our Zoom meeting. And I'd like to welcome the new fellows and also all the attendees. Thank you so much, Mayra, and your team. Thank you, Mafaz, for taking care of the meeting. So I'm going to share the agenda, and then Mayra, if you want to start with your team.
Sure.
Just
Absolutely.
a second. Go ahead, Mayra.
Okay, well, welcome everybody. My name is Dr. Mayra Mesoni. I am the team leader of the Lyme group, and we are happy to help you with this meeting today. For the presentation today, we have on the first topic is going to be perioperative care in older adults, and the presenters is Dr. Dalia and Dr. Mayra, myself. And the second topic is going to be how to develop a mobile app for from scratch, step by step. And this is going to be presented by Dr. Mafaz and team. The third topic is going to be using Excel as a Google Sheet for questionnaire collection of data, how to create a Google Sheet demo. This is done by Dr. Noura Mohammed. Then for the four, we're going to have previous fellow feedback, and this is going to be presented by Dr. Sarah Elsayed. And then the fifth topic is fellow reflections regarding 2023 and suggestions for the new group of 2024 group discussion. This is open for everybody, and we would like and welcome everybody to participate with this discussion. And for the sixth class, we're gonna discuss project update for everybody. This I'm gonna give, if any have any questions, we can ask it at the end, and Dr. Nair will be more than happy to help with this. For the first topic, Dr. Dalia is gonna be presenting the first part of the perioperative care, and then I'm gonna continue in the second part. Dr. Dalia, are you in the chat?
Yes. Hello, everyone.
Hello.
Yes, I will share my
Hello,
screen.
Dr. Dalia. Thank you so much.
Now you see my screen?
Yes, we
Is
see
clear?
it.
Okay, hello everyone. Assalamu alaikum wa rahmatullahi wa barakatuh. At last days of Ramadan, I hope God will accept our hardware and forgive us. Next Ramadan will find us all in good health and everyone accomplish what they want. And I will ask you, please pray for our country, Sudan, to return the peace and pleasure to its area and people. Thank you. Sorry. Our topic today about perioperative care. Our objective to be able to describe how age-related physiologic changes influence preoperative care, risk factor for cardiovascular, pulmonary, renal, and neurologic complications, element of preoperative management of selective medical problems, how to avoid iatrogenic complications. Topic also covers overview of operative therapy for elder people, surgical decision making, preoperative assessment and management, and preoperative and postoperative management of selected medical problems. Surgical is a common treatment for elder patients. We're not surprised about that because it counts about 55% of all surgeries are done in patients more 65 or more years old. Advances in care have lower surgical risk and shifted the risk benefit ratio to favor surgery in increasingly older patients with a more complex condition, which is good. While surgery per se is safer, older adults experience a disproportionate majority of postoperative morbidity and mortality. As a result of normal aging, multiple organ systems may have limited physiologic reserve. For example, cardiovascular and cardiac and vascular stiffening can affect fluid management during surgery or post-surgery. Decreased thermoregulation increased risk of preoperative hypothermia. Stiffening of thoracic cage and diminished ciliary function can affect pulmonary function and decrease pulmonary reserve. Altered body composition, decreased kidney function, hepatic blood flow, and hepatic enzyme activity. This will lead to change in the pharmacokinetic of drug and of course affect the drug to given in surgery or post-surgery or preoperative care. Preoperative care should be individualized. Not all organ systems age at the same rate, even within one individual. We can find one patient with affected kidney, as the other patient with affected lung, the other patient with affected heart. So every patient, we need to take every patient as individual patient. Most older people have one or more chronic conditions that influence preoperative care, either directly or through the drug they use. Thus, older patients require thorough and individualized preoperative care and often benefit from multidisciplinary approach. Pediatric provider should assist in the process of decision of the surgery. Patient's goal of care should be elicited. Surgical consultation should be pursued only if consistent with the patient-oriented goal. So every time we need to talk with the patient and orientate him about the risk of the operation. The risk of the post-operative cardiac event is directly related to age, and this we can calculate the cardiac risk mainly with ASA classification, this American Association of Anesthesiologists classification, or we can use also American College of Cardiology or American Heart Association guideline. These two classification or two risk assessment modality. This slide is very important in assessing the patient before rushing to surgery. And this slide also important for people who are taking step 2 and step 3. You'll find a lot of questions in this slide and you can solve this question from this slide. First thing we need to ask ourselves, is this emergency surgery? Of course, if yes, as is life-saving or limb-saving, we can proceed to surgery. If no, we need to follow major risk factor present. If this risk factor present or no, like unstable angina, myocardial infarction less than 6 months ago, decompensated heart failure, moderate severe valvular disease, or dyspnea. If this factor is present, yes, cancel or postpone surgery, correct acute cardiac condition, reassess valvular function with echo, and also you need to address what's the cause of the dyspnea. If this risk factor not available, in procedure, low risk. we need to assess the procedure if it's high risk or low risk. If low risk, like cataract, endoscopic surgery, or breast plastic surgery, or superficial surgery. If yes, we can proceed to surgery because it's low risk. If no, if not minor surgery, it is a big surgery. Is patient able to do heavy housework, perform yard work, climbing a flight of step, walk up a hill, or run a short distance, as patient can do daily activity? Okay, or he had difficult to do that. If yes, if the patient is okay, can do his daily activity, we can proceed to surgery. If no or unknown, we need to ask ourselves two questions. The first question, is the patient medically appropriate for and willing to undergo testing for cardiac ischemia and revascularization before surgery? This is the first question. The other question, will further information of cardiac risk impact decision to proceed with the surgery or preoperative care? If we find yes to both this question, we need to calculate the cardiac risk. We need to calculate the cardiac risk, as we said, with ASA or ACC or AHA guideline. After we calculate, consider to perform cardiac stress testing, pharmacologic or exercise, and if abnormal, revascularization. We need we get the patient that is patient need for revascularization as CABG or BCI. We proceed for this before do the surgery. If this question, both of this question answer with no to either of them, again, discuss patient risk and benefit of surgery with the surgeon and patient to decide whether or not to proceed with the surgery. Again, not rush to surgery. We need to more discussion with the patient and the surgeon and with the patient who take care of the or people around the patient who take care of him. Preoperative care cardiovascular system. We will take system by system. We talk now about cardiovascular system. History and physical should be performed. History and physical examination should be performed. Supplementary cardiac testing only useful in the following specific circumstances. Preoperative ECG useful as the baseline in patient with a heart disease undergoing non-low risk surgery. If non-low risk surgery, after that we need to do ECG. If the low risk surgery, no need to do ECG. In patient with dyspnea or uncertain cause, consider measurement of liver function, left ventricular function. In patient with a moderate or worsening valvular stenosis or regurgitation, check preoperative echo, if none in past year. If the patient had one in the past year, we check it. If no, we need to do for him echo. Preoperative care cardiovascular, major indication for revascularization in the preoperative period, significant unprotected left main vessel disease, either 3 vessel disease or 2 vessel disease with the proximal left anterior descending artery disease. Survivor of sudden cardiac death with presumed ischemic ventricular tachycardia. If we have this major indication of revascularization, as we said, either BCI or CABG, if there is the main vessels, like left main vessels, or 3 vessels or 2 vessels with proximal left anterior descending. Certain medication given before or after surgery can reduce cardiac and vascular complication of the surgery. Cessation of anticoagulation before surgery in older adult. We need to stop anticoagulation or not. We need to weigh protective benefit versus bleeding risk in patients already on anticoagulation. Do not withhold for cutaneous surgery, dental extraction, minor oral procedure, or cataract surgery. All this surgery, no need to withhold the medication. For other procedure, cessation of warfarin with or without low molecular weight heparin, bridge therapy is the based on patient risk of thromboembolism. So we need to see the risk first before we stop or continue in coagulation drug. Management of patient with coronary stent, in cohort study identify substantially increased risk of major adverse cardiac event when surgery is performed soon after coronary stent is placed. How we can know this soon? They give us time, optimal time for elective surgery, not before 30 days after a bar mental stent. If drug-bulletin stent, it needs 365 days, not before 365 days. Major risk factor for pulmonary complication, patient-related age, like COPD, ASA class 2, and this American Society of Anesthesiologists have classification for that from 1 to 5, or greater. Heart failure, this decrease in daily living activity, or have low albumin. Procedure related is emergency surgery, prolonged surgery more than 3 hours, AAA repair, neurosurgery, or thoracic, abdominal, head and neck, or vascular surgery. All these surgery classify as high risk surgery. General anesthesia is also a risk factor. Only general anesthesia itself is the risk factor. According to 2007 American College of Physician Guideline of Risk Assessment and Preoperative Management for Pulmonary Complication, a risk factor routine to know the risk factor. This is very important if the patient has risk factor or not. Routine chest X-ray not recommended except for non-cardiac or pulmonary disease in patient undergoing thoracic, upper abdominal, or AAA surgery. Spirometry is recommended for patients suspected of but not yet diagnosed with COPD. So the COPD management can be started as appropriate. Spirometry is also indicated for patients who are undergoing lung reduction surgery. Post-operative lung expansion surgery is recommended, and is very important for elderly patients. Accurate estimate of GFR, if we want to take about kidney function, accurate estimate of GFR is important. Renal and glomerular blood flow decrease with age, and muscle mass declines. So serum creatinine may appear normal even when kidney function is not. It is very important to notice the decrease in creatinine. So it may be we can find it normal even if his kidney is not working well. GFR can be estimated by calculating the creatinine clearance using either the Court equation or by relying on the modification of diet in renal disease study and the use MDRD method that some laboratories automatically report. Many drugs used preoperative may require dosage adjustment if renal function is impaired. So renal function is important before any surgery to check the renal function so we can adjust the drug. Preoperative assessment risk of delirium, preoperative risk factor in non-cardiac surgery. This all is a risk factor. Age more 70 or more, cognitive impairment, limited physical function, history of alcohol abuse, abnormal serum, sodium, potassium, or glucose, intrathoracic surgery or abdominal aneurysm surgery. The most important intraoperative risk factor for delirium is blood loss. So we need to avoid blood loss. Patients who require help with the ADLS are at risk of poor surgical outcome. Any patient who have difficulty in daily activity, have no normal daily activity, have his risk is increased post-surgery. Frailty has been associated with a 3 to 13-fold increase in being discharged to a nursery facility rather than home, and higher rate of delirium, cognitive impairment, functional decline, and death. It is important for patient and family member to understand the risk associated with the frailty or poorer function status with the considering surgery, and to consider whether alternative may be appropriate depending on patient goal of care. Avoid any neurologic complications. This is most important in any surgery, but in elderly it is very important. Encourage time out of bed and avoid restraint. Early consultation of physical and occupational therapy may be reasonable. Remove indwelling catheter as soon as possible to reduce the risk of infection and the effect of restricted mobility. Stop IV fluid and lift restriction on diet as soon as possible. Review medication regularly. I think this is my last slide.
Yes,
Mayra,
thank you so much. Yes, thank you so much, Dr. Dalia. Now I'm going to continue, and if you can please pass my slides, I will appreciate it.
Okay.
Well, let's start with postoperative care of hypertension patients. Search for unknown cardiovascular causes, such as pain or urinary retention. Assess for volume status, review fluids administration, and note whether any antihypertensives were omitted. Consider a parental antihypertensive for treating uncontrolled essential hypertension while patients in NPO. Topical agents such as topical nitroglycerin may also be used postoperatively if patient is unable to take oral medications. Then, supraventricular tachycardia postoperative care. First of all, we have to associate with a history of previous supraventricular tachycardia, dysarrhythmias, asthma, heart failure, or premature atrial complex on a perioperative ACG. More common in patients who have a vascular abdominal or thoracic procedures. Attempt to restore sinus rhythm, or at least control the ventricular rate by infusing adenosine and beta blocker or a calcium channel blocker. Then, how we're going to manage postoperative atrial fibrillation. Attempt to convert to a sinus rhythm with electrical cardioversion or infusion of amiodarone if it's poorly tolerated. A risk of thromboembolism is low. Spontaneous reversion to sinus rhythm often occurs within 6 weeks after surgery. First, if the AFib is persistent beyond 24 to 48 hours, increase the risk of thromboembolism. So consider anticoagulation to reduce the risk of a stroke. Then how we're going to prevent heart failure? May develop as a result of excessive fluid administration, myocardial ischemia, or arrhythmia. It can be extremely challenging to ensure optimal ventricular filling pressures by basing the assessment of volume status on physical examination and standard laboratory parameters alone. That's why pulmonary artery catheters have been recommended for high-risk patients, but studies have not shown any mortality benefit, and most authorities advise against this approach. For patients with kidney damage, what we have to do, early signs, you just have to catch early signs of kidney damage, like oliguria, azotenuria, increase in serum creatinine. The mechanism from which this kidney damage occurred, it is an impaired, like one of them is impaired renal blood flow, signaling by an urinary sodium below 40, ratio of urine to plasma creatinine measure of 10/1, or acute tubular necrosis, signaling by the urinary sodium measure 40, and a ratio of urine to plasma below 10/1. Urinary sedimentations may have granular or epithelial cell cast. Or the other type is obstructive nephropathy, especially in men with prostatic hyperplasia, bladder typically is distended and palpable. For the postoperative care and damage, if we have acute tubular necrosis, hold all potentially nephrotoxic medications and meticulously maintain an euvolemic state. Obstructive nephropathy, insert a bladder catheter to reduce the risk of hydronephrosis and impair kidney function. For patients with GI concerns or disturbances, if it's constipation, order laxative and stool softener when ordering opioids and analgesics. Consider suggesting like prune juice if they can tolerate, if they are not in NPO, juices, applesauce, things that help with constipation. Diarrhea, check manually for fecal impactation. This is really important in really older patients. And consider having stool specimen checked for leukocytosis or Clostridium difficile toxin. Focus carefully on volume resuscitation and treating the underlying causes. Now the perioperative care for patients with type 2 diabetes. Oral drugs are usually held the day of the surgery, especially like metformin, which theoretically may increase the risk of metabolic acidosis during stress time. One option is to manage glucose during periods of prolonged fasting. First is administering an IV glucose-containing solution at a constant rate while closely monitoring blood glucose by fingerstick assay. Or administering subcutaneous insulin as needed to avoid severe hyperglycemia until the patient can resume eating. Many type 2 diabetics who will be fasting for less than a day can be safely managed by withholding long-acting diabetic agents and treating hyperglycemia with a short-acting insulin alone, like sliding scale. Vigilance is important. Diabetic patients are at substantial risk for both hyper or hypoglycemia in the perioperative time. Insulin use in patients with type 2 diabetes. Day of surgery, hold the outpatient dose of insulin and give a sliding scale of insulin as needed. First day of eating by mouth, a general rule is that giving half of the outpatient dose of diabetes drugs with a sliding scale insulin as needed. When patients can consume their usual diet, resume the full dose of diabetes medication. Now we're going to speak of patients using corticosteroid treatment. Perioperative administration of a stress dose of steroids is appropriate for patients on prednisone of a dose of 20 milligrams a day for a measure of a week, patients with no adrenal insufficiency. If there is a dysfunction in hypothalamic pituitary adrenal axis function, then measure cortisol first. Then cortisol is not elevated, consider a 30 minutes ACTH stimulation test. Now we're gonna discuss the reducing the risk of delirium. This is one of the most frequent causes of complications in the postoperative. When preoperative risks are present, clinicians should be especially vigilant about reducing sleep interruptions, reducing dehydration, encouraging mobility, avoiding restraints, enhancing sensory inputs, minimizing medications, controlling pain and constipation, and correct electrolyte abnormalities. A syndrome distinct from delirium characterized by abnormalities in learning and memory. Most common after a cardiac surgery, postoperative cognitive dysfunction. It is a syndrome totally different to delirium. It's characterized by abnormalities in learning and memory. It's most common in major surgeries like cardiac surgeries. It persists for many, many months, and it's not demonstrated to any links to hypotension, hypoxemia, or type of anesthesia. And the treatment is supportive. Now we're gonna speak about pain in postoperative care. The oldest all in cognitive impaired patients are the highest risk for undertreating of pain. Most post-surgical pain requires opioid analgesia. For cognitively intact patients, consider a patient-controlled analgesia or a pump to improve pain relief and lower use of the opioids. If we need to use opioids, may precipitate constipation, and then concomitant use of laxative and stool softener is generally used combined with them. As with any older patients, opioids should be used in the lowest effective dose for the shortest time necessary to reduce risk of association with long-term use. Patients discharged to home and opioid analgesia should be given prescription for naloxone with instruction of how to use it if they tolerate Now we're going to speak less severe pain. Patients may tolerate acetaminophen with narcotics and analgesia as needed if they are able to request it for pain. Patients unable to commit to effectively a standing order for narcotics and analgesias with guidelines as when to withhold and with frequent assessment for medication effect to avoid overdosing or avoid non-steroid analgesia drugs. Potential for GF because they can cause GI bleeding, delirium, fluid retention, nephrotoxicity, or cardiovascular risk. Useful adjustments like ass back, heating pad, massage, and relaxation techniques are useful. It is important here. We have two recommendations. Don't perform stress cardiac imaging or advanced non-invasive image as preoperative assessment in patients scheduled for surgery with low risk of cardiovascular surgery, because this is high costly effective and it is invasive for patients. Patients who have no cardiac history or good functional status do not require perioperative stress testing before non-cardiac thoracic surgery. Do not perform perioperative medical tests for eye surgeries unless there is a specific medical indication. Avoid echocardiograms for preoperative or perioperative assessment in patients with no history of symptoms of heart diseases. Don't order coronary artery calcium scoring for perioperative evaluation for any surgeries irrespective of patient risk. Don't initiate routine evaluation of cardiac artery disease before cardiac surgery in the absence of symptoms or other high-risk criteria. Before cardiac surgery, there is no need for pulmonary function testing in the absence of respiratory symptoms. Don't obtain preoperative chest X-ray in the absence of clinical suspicion for intrathoracic pathology. Now I'm going to go through a summary and then we're going to do some questions. Surgery. It is important therapeutic option for many older people. Preoperative assessment should be individualized, target, comprehensive, and often multidisciplinary. Attentive perioperative management minimize complications in older patients, especially those with chronic medical problems and functional impairment. Now we're going to do case one. This is a 70-year-old man who comes to the office for a perioperative assessment. He's scheduled for a total hip arthroplasty for sharp, severe, non-radiating pain in his left hip. He has stopped walking because of the pain and depends on his wife for the meal preparation and most household chores. History: he's hypertensive, has diabetes, chronic kidney disease, and osteoarthritis. Medications: he's on insulin, atorvastatin, acetaminophen for pain as needed. So now I'm going to give you the options and you guys, evaluation. Active range of motion and left hip is limited by pain. The ECG have a normal sinus with acute wave in lead second, third, and AVF. Laboratories have a bone of 38, a creatinine of 2.1, and an hemoglobin H1C of 7.4. Let's see. Which of the following is the most appropriate next step? I'm going to give you a minute to answer in the chat. Coronary angiography, first, what we're going to do. Coronary angiography, B, exercise treadmill test, C, pharmacologic stress test with imaging, D, no further test necessary. What do you guys think? You can put your answer in the chat. I see C, C. I see a under C. I see an A. Okay, let's remember again, it's a 78-year-old man. They're gonna do a hip arthroplasty. He's hypertensive, diabetes, chronic kidneys. He takes insulin, atorvastatin. So this is from what we read before and what we learned before. The correct answer is gonna be D, pharmacology stress test. This patient, we cannot put him on a treadmill. He cannot walk. Coronary angiography, he do not have from his AKG like a baseline cardiovascular disease. Entonces that's why we're gonna do option C, pharmacology stress testing, just to assess any coronary damage or angina in the process. Then case number 2. 72-year-old woman with pancreatic cancer undergoes resection with a Whipple procedure. Surgery is uneventful, but her mental status changed abruptly first day after procedure. She's awake, combative, and agitated. She believes that she's at home and that her daughter is holding her against her will. The nurse reported that she has been in such an episode, has 2 episodes like this in the postoperative period. Examination, blood pressure is 112/80, heart rate is 106, and she's disoriented. The abdominal incision is not edematous, and it is unremarkable. Which of the following is the most appropriate next step? A, obtain electrocardiography and measure cardiac biomarkers. B, request neurology consultation. C, administer of lorazepam. D, administer of vancomycin and cefepime. What do you guys think? I see A, I see C, C, I see C again. Okay, well, the correct answer for this is gonna be A. We have first to check, remember that the first complications that we can have when we have patients that are under stress, blood loss, we have to check electrolytes. We first check. We do not treat, we have to check the overall status, and then we can treat with medications any pertinent of the cause. And we first obtain electrocardiography, measure cardiac biomarkers, because of these options is the only ones that is going to give us a little bit of an answer of overall status of the patient. Then in the last case that we are going to see is going to be a 60-year-old man comes to the office for preoperative assessment before an elective resection of parotid adenoma scheduled to take place in 2 weeks. Other than facial swelling, he feels well and has no symptoms. History of diabetes mellitus, hypertension, and chronic atrial fibrillation. Okay, he has AFib. Medications, he has amlodipine, apixaban, and metformin. Okay, entonces, which of the following is the best approach to manage the anticoagulation pre-operatively? A, we stop apixaban 2 days before surgery. B, stop apixaban 2 days before surgery and bridge it with low molecular weight heparin. C, stop apixaban 2 days before surgery, bridge weight on fractioning heparin, or D, continue apixaban. So what do you guys think in this one? I know it's a tricky question. He's getting a surgery of a resection of parathyroid adenoma. Okay, we have to check risk and benefits from stopping this medication. And the correct answer for it is gonna be A, stop apixaban 2 days before surgery. Okay. Well, this is the end. This is the end of our presentation. I hope you guys enjoy it. And should I have any questions, just let us know.
Thank you both for great presentation.
You're welcome.
So if any questions or any comments, please go ahead. Dr. Winston, go ahead.
Yeah. Dr. Nadia, I found why the last question it was option A, to stop it at the second day, and it's because you have to determine the thromboembolic risk of the patient, and that we use, the SHA2 DS2 Basque scores that will give us his risk of thrombotic event, and to determine the bleeding risk of this patient. There is another scale, the HAS bled, and with that, that's why we stopped the anticoagulation just 2 days before, for overall anticoagulation of the patient in the surgery.
Sounds good.
I can share the paper with you guys if any of you want to read it.
Sounds good. Thank you so much for sharing.
You're welcome. And bye. I hope you guys have a wonderful day.
You too. Have a good one. Good one. Enjoy.
Thanks. Bye.
Thank you so much. Yeah, bye-bye.
Bye.
All right, Dr. Lema, if you have a question, please go ahead or comment.
Oh, yes. Thanks so much, Dr. Nadir. Thank you for both presentations. It was a great presentation. I just have 2 questions. So on the second question, it was mentioned that the patient has been combative. So if the patient has been like behaving like that and is combative, so is it not like first to stabilize the patient and give lorazepam before going to EEG? How do we proceed with the procedure if the patient is already combative? That's the first question I have.
Dr. Dalia, do you have any answer?
Yes, I think this patient, we need to exclude delirium and the cause of the delirium. So we cannot give lorazepam because this will exaggerate the problem. So we cannot give any type of benzodiazepine. Only we can use with delirium is haloperidol. But before that, we need to know the cause of that, cause of delirium. So the very thing we need to exclude the most important and serious. That is why we do cardiac evaluation to exclude any MI, any problem in the heart. After that, we will see what is there. But we will not give benzodiazepine in delirium if we suspected delirium. Dr. Nadir, if you have comment.
No, I totally agree with you. Yeah, if you suspect delirium, yeah.
Okay, thank you so much. Yeah.
Thank you. Dr.
Hello, everybody.
Hello, Assalamu alaikum, Dr. Rahman. Go ahead.
Alaikum assalam. How are you?
Very good.
Yeah. So I have a little comment about good presentation, well covered topics, and the preoperative evaluation for non-cardiac surgery is really a very important one. And I'm just try to mention takeaway points. For emergency surgery, as you know, really we don't need to, we will just evaluate risk and benefits and go for surgery. For the elective surgery, then we tackle the patient according to comorbidities. For you, and I want you to know these things, like from the history, you can really evaluate. The best evaluation is from history. Is the patient having any shortness of breath? Is he having any chest pain? Like any sign that clearly mentions that this patient is not going to undergo surgery at the specified time. And for example, if he's edematous, if he has ongoing infection at the site of the surgery, because this is something very clear and you need to take care of that. The other thing is that the big things, hypertension, diabetes, coronary artery disease, renal failure, is he on dialysis? So all these things are very important, because if you look at this picture, you are going to catch a lot of things. Don't like take the details and forget about the bigger picture, just the big things. The other thing is then you come to medication list. This is important. Is he taking aspirin, Plavix? If he has stroke recent or recent myocardial infarction, that is important. The other thing is usually aspirin will be held for 7 days and Plavix for 5 to 7 days. So when tackling about any medication, I want you to know this, when you talk medication, think about the half-life of the medication. This is a pharmacokinetics. In medication in general, we talk about 3 things. Let's talk about 2 things right now, pharmacokinetics and dynamics. Pharmacokinetics, what the body does to the drug, excretion, absorption. But pharmacodynamics is what the drug does to the body. So right now we are dealing with the pharmacokinetics, especially, for example, you have a question about apixaban that will be held for 2 days. Why is that? Because the half time is 12 hours. This is in a healthy, for example, with a patient with a healthy liver function. But if he had liver issues, it could be longer than that to be cleared. Okay, so that is something we need. If you hold any medication, know something about the pharmacology of that medication. It is simple and easy. And we mentioned too about medication pharmacokinetic dynamics and genomics. Genomics is something different. That is a field of individualized medicines. And it happens sometimes we need it because patient on Plavix and still he has stenosis, in-stent stenosis, like stenosis inside the stent. And because he is not metabolizing the Plavix, that is different thing. So medication list of importance and history of importance, and then your surgery, is it a high-risk surgery or low-risk surgery? For example, vascular surgery is a high risk, and when we come to cataract surgery, is something of a low risk. So that is also, it gives us a clue on how to deal with perioperative patient. But right now you are tackling a very special group of patients who are elderly. Okay, so that is the history of fall, the history of delirium, and the history of complication like nausea or perioperative delirium on the previous surgery. That is important. That is simple. That is kind of a low-hanging fruits because, oh, he has this happen to him before. So it is likely that he can have it again, and then you will prepare your team. Having said that, you communicate your evaluation with the team, with the surgeon. And this is very important. And the other thing is that communication matters, and that will help you not just dictate your notes and just talk. And the other team member you can talk to is the anesthesia, because he's going to be evaluated by anesthesia as well. I don't want to take more from your time, but it is very nice topic, nice presentation, nice questions, and thank you.
Thank you so much, Dr. Ahmed, for the great comments and excellent points. So I want you to take home these points because it's important for your patients when you are evaluating them before surgery.
Thank you.
So if there is no more questions, we can move on. Samia and Alia, did you raise your hand earlier?
Thank you so much, Dr. Nadir. No, I was just going to say the same thing that Dalia mentioned about delirium and that we should avoid benzodiazepine. Thank you so much.
I appreciate it. Thank you so much. All right, if no more questions, we can move on to the next agenda. Item in the agenda.
Hello, good evening, everyone. Before we move to the second agenda, there's a question in the comments from Dr. Isra. She's asking, why is apixaban not bridged with LMP, LMW heparin before surgery? If Dr. Dalia is here, you can answer it, please.
Yes. I don't know if we can bridge with heparin, apixaban with heparin. I think bridging only for warfarin, because warfarin it takes 5 days to work. That's why we bridge with heparin. And in the beginning we stop apixaban to not cause bleeding. Why we need to put other heparin? I think this is my answer. I don't know. What do you think, Dr. Nader?
Yeah, I agree with you. So when you are evaluating the patients, as Dr. Ahmed was mentioning, you look at the medications. So the new DOAC, most of them, they will have a long period of half time. So usually we ask to stop the patient taking the medication 1 or 2 days, because as the government mentioned, it takes 12 hours to clear the medication, maybe longer than that. So by longer than that, the body will have some sort of the medication. So the blood thinner is working there. So there is no chance for getting the clots formed before the surgery or during the surgery. And they can restart the medication right away. So there is no need for the heparin or other antibiotic during that period of time. However, in certain medications, sometimes we look at the condition as well. So if the patient is taking the medication for a condition that's highly thrombogenic, that means the chance of thrombosis is higher. If we stop the medication, the period or the window of the anticoagulation is longer, is where we will jump with some bridging. So in this case, I don't think there is a chance or there is increased risk, and the medication will last in the body, but it's not going to be as risky for bleeding. If you continue it, the risk for bleeding will be higher during surgery. So it's kind of a very gentle balancing between the risk of thrombosis versus the risk of bleeding. So in this case, you can stop 2 days and then you can go for procedure. You don't need the bridging. And as mentioned, bridging, most of the time we use it with comedine. Because comedine, you need to stop and you need to check the INR, and if it's less than 1.5 or something like that, then you go ahead. Thank you. Dr. Farah and Dr. Wala mentioned that also in dental clinics, when they want to do procedures, they also need to check on the medication list, especially anticoagulation, and they need to stop the anticoagulation in certain condition when there is risk of bleeding as well. So also the dental group, sometimes they ask the primary physician, can you clear this patient for procedure? We are going to remove or going to do this and that. So you also think about this before you send the patient to the dental clinic. Dr. Ahmed, go ahead.
I think another reason for why we need a heparin bridge for warfarin is because warfarin can cause skin necrosis, because it initially causes a hypercoagulable state, because it suppresses protein C and S before suppressing other coagulation factors. And that's why there is initial hypercoagulable state. This can lead to a skin necrosis. So we have to provide heparin before, like simultaneously with warfarin. So this is another reason.
Thank you so much, Dr. Amal. And just to clarify, the question in the answers mentioned is to stop the drug and then put the patient on bridging until the procedure, and then after that, we continue bridging. What Dr. Amal mentioned is the risk with comedian is that when you initially start the comedian, there is a risk for the problems that she mentioned. So you don't want them to get problem that when you stop the comedy and go to the surgery, and after the surgery you want to start the comedy, you need to bridge at that time. Thank you so much, Dr. Ahmad, for clarifying. If no more questions, we can move on to the next item of the agenda.
Yes, good evening, everyone. Our next agenda is how to develop mobile application using websites, different websites. I'll be sharing my screen. Dr. Nader, can you allow me to share the screen?
Just a second.
Yes, I hope my screen is clear for everyone.
Yes.
I'm Mafaz. I'll be presenting about mobile application development. My objective today is to discuss the introduction regarding mobile applications and different engines that we have used in the past, as well as ways how to develop an idea for an application, and how to research the available products that's available in the different app stores, and also how to develop mobile applications and a practice interactive mobile application development. So the different engines that we have used in the past include Glideapp, MIT, and Codular. We have had past fellows produce applications in these three application developers, as well as the Buildfire application builder and Andromo app builder. There's also other different websites. So with each of these application developers, there's a pros and cons. When it comes to Glideapp, it is a non-code application or a non-code website developer application, and it allows you to access Androids as well as iOS softwares, which means you can access different Samsung's devices as well as Apple devices. When it comes to MIT and Codular, the finished product will be accessible only in the Google App Store, which is only accessible to Androids. And similar to the Glideapp, the Buildfire and Andromo has a similar iOS and Android feature. How to develop an idea. When developing an idea, you have to choose an interest of your specialty, target your population of interest, as well as what is the benefit or what is the issue that the idea serves in terms of public health or your specific specialty. And lastly is what unique feature do you have in your application in regard to the available products in the market. Where to start searching. So in our app developers, it's either Androids or iOS. And these softwares will give you access to mobile phones, tablets, and some laptops, as usually laptops use Microsoft as their software. So when we research an Android software and iOS software, we're looking at the Google App Store and the Apple Store. When we research, we're looking for the default features, which has to be in each and every application, as well as we're developing our specific or special idea or feature. that is to be in our application. How to start? Our first step is to find our website or our app developer. So as I mentioned, Glideapp will give you a final product that is accessible to all softwares that use Android or iOS. The downfall or the con of this Glideapp is that the link to the application or the QR code has to be physically presented to the users. So if you have a small surface area or a small population of interest, it will be very accessible and to also allow you to share it outside the population of interest. When it comes to MIT and Codular, it's accessible only to Androids, so it's accessible through the Google App Store. And in this way, it is very easy for the users to download as it's already in the Google App Store. It just needs some advertisement, and the users can easily access to the Google App Store through MIT and Codular. Now for our example, we'll be developing an application together using Glideapp Builder. The population of interest is e-cigarette smokers. The benefit or the issue that this application serves is to calculate the risk of developing lung disease in e-cigarette smokers. What is the unique feature is that it will approximate the lung disease risk in e-cigarette. Of course, this is not factual. I have made up these numbers, these results, so they're not factual, they're just for the purpose of this example. So our variables are the age, 3 ranges from less than 18 to 18 to 40 and more than 40 years old. And if they're current smokers or not smokers, the years spent smoking from less than 5 years, active smokers, 5 to 10 active smokers, or more than 10 years. And then we have our scale. There is no risk if the person is less than 18 years, they're not a smoker, and they have smoked less than 5 years. Low risk if they're less than 18, they're a smoker less than 5. High if they're 18 to 40, they're a smoker or they have smoked from 5 to 10 years. And very high if more than 40 years old, smokers, and for more than 10 years they have been smoking. So we'll move on to our Yes. So when it comes to the Glideapp, I have just logged into my Google account. And before we start the Glideapp process, we have to actually make our Google Excel sheet, because our Google Excel sheet, it acts as a source for us for the application. So we're going to make a blank screen. We're going to name our spreadsheet Yes, we're going to name it e-cigarette risk assessment. Okay, so for our first calculation or our first risk assessment, we need 2 sheets. One sheet will be for the question. So our first question, our second question, third, and the fourth. So our first question is the age. The second is if their smoking status, and then their years of smoking, and then their risk, right? So here I'll just write risk, and then I have to leave this column empty, and then I have to write my answer. So the answer is the variable for the first question. So for example, question 1 is the age, less than 18, 18 to 40, and more than 40. So in my answer 1, I'll write less than 18, and then answer 2 for question 1 is 18, 40, and then here has to be answer 2, and then answer 3, which is more than 40 years old, and then for answer 4, it is the smoking status, which is either yes or a no. And then for the smoking, for the years spent smoking, for question 6, there are 3 options. So they have either been smoking for less than 5 years, or they have been smoking for 5 to 10 years, or smoking for more than 10 years. That is answer 8. Is this clear for the first sheet? Okay, we'll move on to the next sheet where we write our choices. So our first choice is the age, less than 18, 18 to 40, or more than 40. So to write this, we'll just say less than 18, underscore 1840, underscore more than 40. And then here I'm going to write less than 18 years old, 18 to 40 years old, and more than 40 years old. Now it's the smoking status, yes or no. So yes, underscore no. And then I'm going to write yes and yes and no. So can someone tell me how I'm going to write the current years spent smoking, which is less than 5 years, 5 to 10, and more than 10 years? Is anyone able to help me write the cell for the years spent smoking? Okay, so it seems like it can be a bit tricky, so I'm going to write it down. So it is the choices. So my choices are less than 5. So it is less than 5 years. I'm going to write it over here. Less than 5, 5 to 10, and more than 10. So in order for the system or the Glideapp to read it as a choice, it has to be written in the form of the choice 1 underscore choice 2 underscore choice 3, and so on. So when it comes to this, this example, I'm going to write less than 5 years spent smoking underscore, 5 to 10 underscore more than 10. And then I have to write them individually as they are choices. So less than 5 years, 5 to 10 years, and more than 10 years. And this was for the sake of the example, I'm going to delete them. So these are our choices, and this is our questions and answers in terms of the answers to each question. Now I'll go to my Glideapp. Yes, I'll go to my Glideapp. I need to form a new application, and I'm using a Google Sheet for my source. Click continue. And now these are my files, and this is the file that we want to choose, or this is the file that we just created. So the e-cigarette risk assessment. Okay, so at first it comes like this, but this is not the way that we want it. So we're going to delete, and this is our first sheet. It should not be sheet 1 and sheet 2 as like this. So we're going to delete sheet 2 from here, and we just have sheet 1. So this is our first source. We need to make a text for the question. So our first question is, what is your age? And then we have to make a choice. So we go on and search choice. Okay, and our source is the sheet 2, which has our first choices for the age. So we have less than 18, 18 to 40, and more than 40. I do not want them to be a drop down. I want them to be chips. So I'm going to choose chips, and these are our choices. Over here, we have this that says write to question 1. So what this means that in our Excel sheet, when a user chooses less than 18 years old, it's going to change in our Excel as less than 18. So for example, if I choose 18 to 40, it's going to be over here. It's going to be written over here as question 1, 18 to 40, as you see it here currently. So I'm going to write the second text, which is the smoking status. So it will say, are you a smoker? Can someone tell me how I'm going to make the second choice?
Yes or no?
Yes, it is a yes or no, but how do I make the choice exactly? How do I go on and navigate how to make the choice? So I will first choose, right? I make the choice, I search for it, and then what do I do?
Go to sheet 2.
Yes, so it's going to be my source at sheet 2, and my values are the
Yes or no?
yes. And then I don't want the drop down. I would like the chips, so I'm going to choose the chips. And now if I choose yes, my answer would be written to question 2 in the Excel question 2. Yes, thank you very much for participating. Now, can you tell me how I'm going to write the third question?
Choice.
No,
text.
So for text, yes, very good. Thank you very much. So it's going to be a text. And my third question is, how many years have you spent smoking? Okay, and then how do I make the third choice?
You go to choice, then sheet 2. Then
Yes, thank you very much.
5, 10, 5, 10, less than 5, something like that.
Yes, thank you very much. Yes, excellent. And I'm going to change the style. And this is your preference. So there's chips, there's drop down. So it shows like this. And then there's also a radio button. So it shows like this. But I prefer the chips because it's easier for the users to use. Now, can someone help me to write the fourth question?
So again, you go to text, write the question.
Yes, thank you. So I'm going to write here, risk assessment.
Then you go to choice.
Now this is different. So yes, thank you very much. So regarding the choices, for the age, for the smoking status, for the years spent smoking, they're all similar when it comes to choices. However, when we're writing the risk, we want only one answer to show up for the users, right? So if they have no risk, it has to show as less than 18. They're not a smoker, and they have obviously not smoked or smoked less than 5 years. And over here we'll have the no risk show up as the assessment. So when you have an application that you're developing in such a way that has to be only one answer that shows up according to the user's choices, it will be in the form of texts. So instead of the choices, I'm going to now make another text. So I'll make a text. I'll say no risk. Okay, can someone help me write the others risk assessment? So the low risk, the high risk, and the very low, very high risk. Yes, can someone help me write the low risk? So in which, yes.
I think you would select 18 to 40, then select yes, then add the text like the previous one. Then let's add the risk.
No, so I cannot make the risk as a choice because the risk has to come as one answer according to the user's choice. So when it comes to risk assessment, one answer choices, it has to be in the form of text. So I'll make another text. I will label it as low risk. Yes, is this clear?
Can I have a comment or question?
Yes, yes.
You said like here, 18 years old, you are a smoker. No. Should we add how many years spent smoking, like none? So
We can add this, yes. Just give me a second. We're going to go to the Excel sheet and then we will go to our sheet 2 and we can add over here years spent smoking. We'll say over here none, underscore less 5, 5 to 10, and then I'm going to shift these so I can add my none over here, okay? Now, since I made a change in the Excel sheet, right? And this is my source, I will have to go to my application and I'm going to click over here in data. And once I click on data, I'm going to go over here and manually sync my data. So I'm going to click it. This way, whatever change I made in the Excel sheet will translate into my application or the Glideapp spreadsheet, my source. So now I'll come back here to my layout. Okay, and it has changed. So now I have none for my answer. Is that clear?
yes.
Yes, thank you very much. So can someone help me write the third risk assessment, the high risk?
Then again, text.
Yes, thank you very much. Yes, thank you very much. It's going to be text. Now it will be high risk. And then for the final one, again, it's text. And it is very high risk. Okay. Now, yeah, so there's this question 1, right? It doesn't look very user-friendly. It can be confusing. So how do we change it, right? This is part of the choice. So I'm going to go to choice 1. And this is the label. So I'm just going to say, I'm going to do it as choice 1. Yes, so this is my choice 1. And then in choice 2, can someone tell me where can I remove the question 2 and label it as choice 2 instead?
Just go to the label down.
Mm-hmm.
Yeah, delete it and write whatever you want.
Yes, thank you. So I'm going to go here, change it to choice 2. Then can someone help me with choice 3? How to change the label?
Yeah, go to choice 3, then go to label and write choice.
Yes. Yes, thank you very much. So choice 3, and we changed it. Now it's the trickier part or another part of the assessment. Now I need to make the rules. So when I choose 18 to 40, smoker less than 5, I have to get a specific assessment. Right? Yes, so now I'm going to go to my list, my components. This controls everything that you have added. I'll go to the end and I'll go to my no risk and we'll go to options. And in this area, I have the visibility. So literally it means that I control when does this button or does this text appear. So I'll go to my conditions and now I'm going to add conditions. So I want the low risk to show when the component A, the question A, the one that has the age less than 18, 18 to 40 or more than 40 is. So no risk means that the person is, sorry, hold on, go back to options. Yes, so I want the first choice to show the no risk if the first choice is the age less than 18. So I'm going to come here, I'll say less than 18 years old. Another condition is and question 2 or choice 2 is no. And the third condition is that the question 3 is none. So now the none or the no risk has disappeared. So if I choose the less than 18, not a smoker, and none, the no risk appears. So can someone help me how to write the low risk options or the low risk visibility conditions? So for the low risk, I need the choices to be less than 18 years old, a smoker, and have been smoking for less than 5 years. Okay, so it is a bit tricky. So I'll do it. I'll try to do it very slowly. So the question 1 or the choice number 1 has to be is less than 18 years old plus another condition in the choice or the yes, and the second choice is a yes, so is yes. My third choice is less than 5 years. So now if I make the changes, less than 18 years old, a smoker and have been smoking for less than 5 years, the low risk appears. Can someone help me do the high risk assessment or the conditions? So my high risk is a person that's 18 to 40 years old, a smoker, and have been smoking for 5 to 10 years.
Well, we can add the 18 and 40 years old and more than 40 years old as well.
Yes, so can you help me? How do I write it over here? So what do I make the changes? Yes.
Which one is
Mm-hmm.
enter the value 18 to 40,
Yes.
and you can add another condition within question 1 itself and make
No,
it.
it has to be question 2, right? It's a different choice. So question 2 and then?
Okay, question 2 and make it yes.
Yes is yes. And then?
Then you go to question 3.
Mm-hmm. And I'll change it to?
Is to more between 5 and 10.
Mm-hmm. So 5 and 10 years. So now let's check out our choice that we made. So we said 18 to 40 years old, a smoker, and has been smoking for 5 to 10 years is a high risk, and it has appeared. So we have done it correctly. Before we go to the last choice, I would just like to mention one thing. So we have written the ages as less than 18 years old, and then it's a yes or no, and the years spent smoking as years, right? So we have to follow the specific spelling that we have used. We cannot make a condition and use, for example, less than 5 year or 18 years old or just 18-year-old. It has to be the same format or the same spelling as each choice for the visibility to work. So it's something to remember always. Now to our last visibility or our last assessment. Can someone help me do the conditions for this last assessment? For this one it has to be more than 40 years old, a smoker, and more than 10 years old, or more than 10 years spent smoking.
I think you would choose the question and the condition and the question, and we choose one.
Yes, so I chose the question 1, so it's the first choice. Now what do I need to do?
Is more than 4 years.
Yes, so I have to change over here. It has to be the first choice has to be or is more than 40. Yes?
Over 40 years old.
Yes. Thank you. And then what else do I need to do?
Add another one to the question, second the question.
Yes, I added it.
And like the first one, like do with ears, then yeah, question 2.
Yes, thank you. And then I change it to question 2. And what do I need to do? Another thing?
Is not empty. Change it to ears.
Yes. And then it is
answer. It had to be a smoker. Yes.
Yes, thank you. Yes, and then?
And then add the third condition. Question choice 3. Number 3. Then is not empty. Change it to ears. Then like more than 10 years.
Yes. So it's more than 10 years. So now let's check our choice that we have made. So we said more than 40 years old, a smoker, and has been smoking for more than 10 years is in fact very high risk. Is there any questions regarding this step?
The step is clear, but I have a question between high risk and very high risk. Can we tailor this question because group age 18 to 40 and more than 40 can fall in the same high risk and very high risk?
I understand your question, but this is a very not factual example that I have just made up for the sake of this for this presentation. So it's not accurate. Yeah, it's not an actual example of a very factual data flow or any an example that we can use. It's just for the sake of the example. Yes, thank you very much for the question. Is there any other question? Okay, so we can also change this sheet 1. So you can just click on the blank screen over here. We'll go to general. Okay, and this is our label for the sheet. Now I can name it the assessment. Okay, and now it's called assessment. And the name changes on the top of the screen as well as the lower menu. Is there any other features that you would like to add to your application?
On risk of diabetes or hypertension or anything?
Oh, so you would like to add another condition?
Oh, yes.
Okay, so yes, that's very fine. So can you help me add the condition to the Excel sheet?
You add one more question.
Okay, so I'm going to change the question for. I'm going to make my, for example, diabetes, right? So diabetes, and then over here, I'm going to add my question 5, which was the risk. But now I need a space. So I'm going to go over here. I will just cut and paste it. So I have my space between the columns. So I have this empty space between the questions and answers. Okay, so I added the first question, but I need to add my choices in the other sheet. So what's my current conditions that you want to add?
Yeah, yes or no. I mean the answer response for diabetes.
Oh, so you just want to add does the patient have diabetes? Yes or no, right?
Yes.
Okay, so I misunderstood you. So I'm just going to go over here, and this is a yes or no question. Okay, so I'm going to go to the other sheet, and how do I start the process of the yes or no question? Can you help me?
Underscore yes, underscore no. Is that
Yes, thank you very much. So it's a yes underscore no, and now I have to write my yes and then my no, right? So
yeah.
now
And
I'm
similarly, we
going
can
to,
add other like comorbid conditions as well, right? Like if you
yes,
want to have
yes,
like
the same way we can add any conditions that you want to add. Yeah, so it's a very simple process. Once you know the way, then you can add anything you want. Yes,
thank you.
thank you. So now I'll go back to the sheet. Can you help me? How do I add the condition that I just added?
You go to again text.
Okay, so I'm going to make my first question for it. So I'll write text, and yeah, I'm going to choose it. So my question is, do you have diabetes? Yes. So now my question appears after the risk assessment, right? I don't want it to appear this way. So what I can do is I can just pull it up. I just drag it to where I want it. So where would you like this question to be? After, like, under which factor or which variable?
Yeah, after how many years you have spent smoking.
Okay, so I'm going to drag it all the way. Okay, now it is here. I have to drag it again up. So you want it
After the last question.
you want it after the age or after the
No, after the how many years you have spent.
Yes, I think I moved the wrong one. Okay. Is this how you want it?
I think it went right up, but I think you just need to drag up for okay.
You want it under the how many years you spent
smoking.
Okay,
Yes.
okay. Now I got you. Okay. Over here. Okay. Is that perfect for you? Yes.
Yeah, that's correct.
Okay. So now how do I make the choices for this question?
You go to choice.
Mm-hmm.
You select yes or no. You select from the sheet 2.
Okay. Yes, perfect. Thank you very much. So my sheet 2, and then my values, right? Yes or no?
Yes.
And then I liked my chips, so I'm going to change my style to chips, and I will just change my label. So this is my choice 4. Okay. So now I added a new choice. Can you help me, like, which risk would it add? Like, if someone does not have, oh wait, yeah. So again, my choice, because it's the last thing that I have added, so I need to pull it up to be under the right question. Okay, so remember to always pull it up, so it's under your question, under the right question. So now it is aligned. So do you have diabetes? It's a yes or no question. So how do I make a condition for this choice? right? So
Not moderate risk. Do you have?
So someone, if someone does not have diabetes, so let's start with no risk, right? So let's go to the options, and then we're going to add another condition. So our choice 4, right? Our question 4, someone is less than 18 years old, is not a smoker, have not smoked anything for whatever years, so they're non-smoker, and for their choice 4, they are non-diabetic, right? So is no for the diabetic, right? So they are at no risk, for example, right?
Yes.
Yes. So now let's see. So we said less than 18, they're non-smoker, they have not smoked ever, and they don't have diabetes, so they're at no risk.
No risk.
Right? So do you want to help me add this condition to the low risk?
Yes.
Yes. How do I add it?
Can we keep it without involving the risk? Like some people will have diabetes without even smoking.
Yes, but we started the main idea of the application as a assessment for lung disease in smokers. But we just
Okay.
added the condition as an example of how can we add variables, right? But you can add, you can remove the risk of smoking. You can add another condition such as stroke and diabetes, stroke and hypertension, with other conditions or other treatment also with the same process.
Okay.
Yeah?
Yeah.
Yes. So I hope this is clear. Do you guys have any other questions, or do you want to practice? How do we add the condition in the other last two? Or please let me know. Okay, I guess I hope that was very clear for you. And if at any point you come up with an idea, please let me know. Or there's someone has their hands up. Dr. Lima, please go ahead.
Oh, yes, thank you so much. Well, it's not related to the one what we were practicing, but I'm being curious that if we can like probably add graphs or pictures on the app, how do we do it? Can you show us some examples for that, please? Thank you.
Yes, yes. So if you want to add another page for example, an image, so I'm going to go over here. I'm going to click the plus sign, and I want a new screen. So this is my new screen, right? In my components, I'll go over here and I have images. So I'll click on image, and this is, I'll just remove my source. So it is a custom. There are no subtitles, also custom, and there's no image. So let's look for an image. Okay, let's say e-cigarettes, right? So I'll search for an image, I'll get the link, and then I can okay, so I'll just right click and I'll choose the image address or the link, and then over here I can go and I can add the URL, and this is the image. I can make it compact, I can fit it to the screen, make it default so it looks nicer. Does this answer your question, Dr. Lima?
Yes, thank you so much.
Yes, so it's very simple. There's we can also look at the other components of what we can add. So we can add a title, a cover, a card, some tables if you would like. Also, for example, we can use it over here in the assessment. So for example, I would like it to look more presentable. So I can use a separator between, hold on. So I click on it and then it's added. Yes, so I'll go to the bottom of my components, and this is my separator, right? So I'll pull it up because I want it to be between the first question and the second question. So I'll pull it up all the way. So now it is over here. Yes, so now there is a separator. It just looks more presentable in applications with users. Another options would be a spacer container for the information. Also, for example, if we use it in the other sheet where we have our image, I can add a rich text. And a rich text just looks more presentable, in my opinion, because I can write over here, e-cigarette, for example. And then I can just add all my information, and it seems more in a title, subtitle, and bullet kind of presentation. So it looks more pleasing. Does anyone have any questions or would like to explore some other features? Okay, so I know it seems more to be a bit complicated in some aspect, but once you practice and you start actually using it, even without having an idea, until you start thinking about one, and then you can reach out to me or reach out to Dr. Amal Alamin. She's very experienced with MIT and Encoder, as well as Glide. It is a very simple process, and it's very helpful, and I hope that you'll be able to gain this and find beneficial for you. So thank you very much for listening. Would you like to add any comments, Dr. Nader or Dr. Ahmed?
This is great. Thank you so
Hello?
much. Yeah, go ahead, Dr. Ahmed.
Nadir, go ahead. I will go after you.
No, I just want to emphasize, thank you so much, Dr. Mafaz. So at the beginning, it may be overwhelming or kind of difficult when you see it, but as Dr. Mafaz did the demo, if you have the idea, you can just put it together and play around, and you will figure it out. Initially, you can start with simple things, and then you can build up complicated mobile app. But thank you. Good job. Thank you. Go ahead, Dr. Ahmed.
Really great job, Dr. Mafaz. يعني really, this is very nice presentation, and thank you for sharing us also in tackling this important apps issues, and I will just make a general thing. Life for today's physician is different when you go 10 years ago. Because right now, if you just look at the medical knowledge and the doubling time of medical knowledge is more frequent. Like, so in order to be, like to update yourself, you have to master the technology, and even you have to take a part on invention. And what Mafaz is doing is really a pioneer work, and this is really very, 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 very nice. And as you know, before, there is some presentation on the artificial intelligence. So all these things are really is going to help us in our career. And this is an education like moment for all of us. Thank you. And really, it is very an excellent presentation. And also like this is also remind us to explore more options as we are mastering knowledge, like medical knowledge as well. This peripheries, and we cannot ignore it. Like, for example, I will just tell you about one of the old cardiologists. I had the chance to practice with him. He refused to leave the paperwork and just he say, oh, like to go on the electronic record is just difficult. I don't want it. But if you choose to do that, you might not be able to practice medicine in this era. So we have to really accept all these things going on right now and just to be part of it. And like Nadia and I from different generation, but not that far. And but for you is really there is a lot of task, and even like those who do like have a degree in computer, they are going to do well, especially in research. One another field, the pharmacogenetics and genomics, I like to talk about this. If you, for example, do gene sequencing, you will have a lot of data. But if you know informatics, that will be easier even to communicate with your statistician as well. I hope I'm not talking about different things, but thank you for your presentation, and thank you for letting the floor to share in your presentation as well. This is good. Thank you.
Thank you very much, Dr. Ahmed and Dr. Nader. I hope everyone found it helpful, and inshallah soon we'll see more mobile applications from our fellow colleagues. Thank you very much. If there are no other questions, we can move to the third part of the agenda. We're going to have Dr. Noura Mohammed explaining how do we use Excel and Google Sheets for questionnaire data collection and create Google Forms. So Dr. Noura, if you're ready, please start.
Hello, everyone.
Hello.
Hello, Dr. Noura.
Yes, hi, everyone. Okay, I have to share my screen. Sorry, only the host. Can I be the host?
Yes, Dr. Nader, do I need to do something to change the host?
Give me a second.
Yes.
Noura, please try again.
Okay. Yes, okay. I think everyone seeing my screen, right? Yes. Can you see my screen?
Yes.
Okay, thank you. Hi, everyone. Hi, Dr. Nader. My name is Dr. Noura. Today I'm going to explain how we can do questionnaire using Excel and Google Sheet. Before we start, I would like to start what is this, when we're going to use that. Okay, so if you remember, when maybe we did the similar to that when we was 4th grade in medical school. We went doing survey, we went to the rural area, and we having all this questionnaire with us. Then we collect the data manually, okay? Then we get back to the college and we give that to our seniors. It is similar process. However, now we're going to learn how to do it digitally, okay? So it's going to be same steps. First, we're going to create a survey. We're going to learn how to create a survey. Then second, we're going to collect the data. This time it's going to be digitally. And last step, it's data analysis. And this is the easiest part. Maybe some of us think it is the complicated part, but it's the easiest step, it's the third step. Okay, so when we do, before we start, when we use that when we do what type of the study? It is the cross-sectional study. Just like a snapshot, we want to know what's going on right now at this time, like how many patients are having a vaccine in this area. Okay, so that's type when we use the survey. So let's start first with creating a survey. Okay, so when we create a survey, first we have to start with the questions. Okay, we're going to use now the Google Sheet, okay? We're going to start with the questionnaire. We're going to start with clicking new questionnaire. Let me show you how we're going to do that. Okay, here. So this is Google Survey. We're going to go to Google Survey. You're going to see here, all the steps is writing down from 1 to 7. Okay, so you're going to click on this, follow this instruction, the second step, the third step. Before that, I would like to highlight what type of the question. You can see here, what is the type of the questions. So when we click type of the question, you're going to see what type of the question you're going to use for the survey. And there is descriptions to give you more idea what type of the question you can use. So for instance, you can use single answer question, you can use multiple choice question, you can use open-ended question, and they give you description, like to have a better idea what question you're going to use. Okay, when we go back, we're just going to follow the instruction and get started, and you're going to start doing the survey. Very easy to do it, just follow the instruction. Okay, so now we're going to discuss the most important part, and it is selecting the appropriate type of questions. And this is the part that you're going to put your effort. Okay, and this is the part that's taking more time. Other than that, data collections and analysis, it is very easy. So let's discuss how we're going to select the appropriate question type. Okay, so this is just for example, we're going to go through this type of the question. First one, it is multiple choice question. When we're going to choose multiple choice questions, we're going to choose it when we want to select single answer. And we wanted the single answer to be clear. Okay, so let me give you an example. Basically, after I finished internship, I had a locum job to do this. They was train us. It was a big study. They just trained us to how to create a questionnaire and how to collect the data. It was a big study. It was about stigma in AIDS patients. So we're going to take that as an example. So when we trained us about that, they say multiple choice question, you use it when you want single answer. So for instance, we can ask the patient, do you have a sexual relationship with the same sex? Okay, so here this question is going to be yes, no, or I don't want to answer. Okay, so this question is going to be wrong. Why? When you have a sexual relationship, it is not clear. You have to be more clear. Do you have a sexual intercourse with the same sex? So here, you're going to be yes or no. So when you choose multiple choice question, ask yourself first, what type of answer I want to get? I want to be a clear, specific answer. So in that time, I'm going to use multiple choice question. So it is the opposite way. You think yourself, what is the answer I want to get? Based on that, I'm going to choose the type of the question. I hope it's clear, not confusing. Okay. Okay. Second type, it is a checkbox question. So when you're going to use that, when you want answer, many of answer, like to gather more information from the candidate. So for instance, like there's a question was, from where you get the HIV? Okay, from blood transfusion, sexual relationship, from drugs. So here I want more options. Maybe the patient even having a sexual relationship and drugs user. And most of the time that's like this is the case, right? In the HIV patient. So you want the patient to gather more information about the candidate. Okay, so that time you see, I'm going to use the checkbox question. Okay, and just make sure you limit number of the choice. So going to have like, see, for instance, you see I don't want more than 5. If I get more than 5 answer for this question, I'm going to exclude this answer. Okay, drop down questions. it is when you ask the patient, it is the best one to give the patient to express himself. So for instance, you ask him, choose the best fit for you the list. So this is the best one to give the patient options to express himself. For instance, was the question about how you describe yourself, homosexual, heterosexual, bisexual. So he's going to select whatever options is going to be fitting for himself, okay? Then we have options, short answer questions. Okay, short answer question, you ask yourself, why and when I'm going to use short answer questions? You're going to use it when you want the answer to be short and clear. For instance, if you remember after USMLE exams, there is a questionnaire, quick questionnaire after the exam. It asks you how much you spend preparing the USMLE. So they give you to put an added answer, right? You put a number. Short, clear answer. That's when you go use the short, clear answer, okay? Then we have the long answer. The long questions, when you're going to use it, when you want to get more in-depth feedback from the client or from the patient or the candidate as well, okay? So most of the time, you see that in the serving industry, when you want to go any service industry, they're going to ask you, please put your feedback, and they give you a box. And they give you instruction, and this is the key. You have to give instruction how to fill this questionnaire, right? So limit of number of words. So for instance, 300 words. And it's going to take you between 5 to 10 minutes. Okay? So far clear? And we have something, a scale questionnaire. Scale question, I think we used to this one. We use that in even medical. We said for patient, if you have a pain scale for me from 1 to 10, right? So here we use it when we need a quantitative measurement, right? When we need satisfactions about the client idea. So we use the scale. And there is another criteria here, data and time. Here you can add, this is like, you can add a data and time for the questionnaire. So it's going to help you to organize. This is just if you want to use it. Okay. So before we file it, I'm going to go back here. So what we did, first we have to paraphrase. The way I think about it, the opposite. First, I ask myself, what is the answer I want to get? Okay, so what is the answer I want to get? Based on the answer, I would like say, oh, what question type I have to ask? Okay, then I'm going to put something called validation rules. As I said, like for instance, if in the long questions, if I get very lengthy one, I'm going to say, no, I have just exceed the limit. So I just have like 300 words. If you exceed this, I'm going to exclude this data. I'm not going to consider it. This is called validation rules. We have something called the branching logic. What is the branching logic? So for instance, we're going to ask the patient, maybe we see that in some of the questionnaire. We ask him, do you use alcohol or drugs? If the question yes, you're going to ask him the following question. So how many times you use alcohol? If the question no, so please go to the next page. So that's called the branching logic. So that means based on his answer, either he's going to go to the next question or he's going to go to the next page. Okay. Then after that, we have something called grouping. Okay, after you finish, now you have all the questions about the topic. So, okay, now we're going to do about a questionnaire about an AIDS patient or HIV patient. So we have now all the questions. Now we have to group them, put them in the group. Why? It is easy. It is easy to respond when they are in the group. Then each group, we're going to put for them headline. Okay, so then we're going to try to answer this questionnaire by ourselves. And now, because we're going to do everything digital, it's not like going to be manual, we have to be optimized for mobile. Okay, because we're going to send it as a link. Okay, from this point. Here, before we finish it, we're going to review the questionnaire. We're going to have a previewing in Excel. If you're going to use in Excel, you're going to have a preview. Click on this clicking preview. We're going to have, you can see your questionnaire. In the Google Sheet as well, you can click in preview and you can see it. Okay, before sharing the questionnaire, so now we finished the questionnaire. Let me highlight the idea. So basically, it is okay, so we're now going to about it, okay? Either two ways. Either you have all the questions, then you try to group them, okay? Or from the beginning, you say, okay, I have AIDS patients. My study is about AIDS, okay? So what is the area that I would like to cover? So I would like to cover background question. So I'm going to ask about background. I would like to cover about sexual history, about to ask about mental health. I would like to ask about drugs, okay? So from the beginning, I group them. So you have either, it is both acceptable, but I think this way, that's why I trained, it is easier. So, okay, in the background questions, what the answer I would like to get? I would like to get a short answer. Okay, so I'm going to use short answer question, like what is education level? So let him answer. I don't need a specific answer. And sexual history, I want clear answer. So because that I'm going to use the multiple choice questions. And the mental health, and so on. You go like that. So you think about the answer that you would like to get. Based on that, you choose the type of the question. Okay? Okay. So now we finished. We create the question. So now we have to share it. Okay, we finished the first steps. So now we have the data collections. Okay, we have to share this link. We have number 2. Okay. Here we have to collect the response. When we go to share this link, okay, we are going to collect a response from the audience, from the client. So we have sometimes we have to use incentive like a gift card to make the patient or the candidate respond to this link. Okay, so either you're going to share this link through email or through social media. So you have your audience. Basically, you have your audience that you would like to share the link with them. Before we go to analyzing, I would like to go here for formatting. Okay, before you go, before analyzing, when you share this link, make sure this questionnaire is in the proper format and the font size is aligned with the questionnaire. Everything is like finishing well. Okay, the layout is you put your logo, you put everything spacing between the questions, everything is clear, everything having a title. Okay, and you have to branding yourself. What do I mean by branding? What I mean by branding, you have to put the logo, organization logo. Then constant in style, like the size, the formatting, because you want to be it very well polished. And you can add image. The image is aligned with your brand. And you have to be theme design, okay? Because nowadays we're living in the picture world, right? This is important how to brand your questionnaire. Let me show you what I mean by that. So recently, I used this slide, okay? So see here, they want me to take a survey. So see, they're using all this criteria. They're using picture, they're using image, you see their logo, and you see their incentive. They're saying, win £100 if gift card, if you're going to answer the survey. Let's see, when you take the survey, okay, sorry. Let's go to the survey, can't find the page you requested. Sorry for that. But you see, because I opened it, I think, yeah. I already take his. Okay, so you see how they're using the advertising, please answer this survey. And you see the survey, they're using all this, the image, even it's going to take you only 5 minutes to complete it. Okay, so this is called branding. You have to brand the questionnaire and you are sharing. Okay, so now we're going to go to the next step. It is analysis. Okay, if you are not lost, we finished the how to create a survey. We create the data and we collect the data. Now we're going to analyze this data. And this is the easiest part. Here, either we're going to choose Excel or we're going to choose Google Sheet for analyzing the data. Both of them, they have amazing analysis tool. Both of them going to give you a report and dashboard for the result as well, and all this graph. Okay, so when we go Google Sheet as well, the same. We're going to give you, it is a quick, it is give you as well a chart, graph, and tables to gain deeper understanding of the data. And you can as well export data from questionnaire. If you are using Excel, you can export data from options. You can customize export. What does that mean? If you don't want a specific question, you want to delete it, you can use that as well. And you can use something called seamless data transfer. What that mean? That means allowing you to quickly move the information into your preferred data analysis tool. Okay? How about importing data into Excel? It is a quick and easy. It is a flexible format. There's including something called CSV and TXT format. It is very easy. It is very easy as well to do data cleaning. So if data you don't want to, just you can easily remove it. And you can visualize your data, okay, to gain valuable insight for your data. Okay, how about Google Sheet? It is as well the same. You can connect the Google Sheet to your questionnaire, and you can easily access and analyze it. And you can customize the layout in the Google Sheet as well. Okay, then we're going to use analytic tool in the Google Sheet. It is very easy to use it. Okay, and we discuss about the branding. This is adding logic and skip logic. It is the same example that I give about do you drink alcohol or yes or no. So if it is yes, you go into more question. If it is no, you skip logic questions. Then you're going to publish a questionnaire. Okay, so you're going to publish it and share it through link, as I said, with others. Sometimes they're adding a code. You can share this code with others. Finally, the best practice for creative, effective questionnaire is to practice it. Okay, to practice more and more. So that's when you're going to use for that. Okay, and putting it together, you have to learn how to create comprehensive questionnaire using Excel and Google Sheet. Now it is time to put a new skill in the practice. It is easy to do it. It's not taking any time. It is effective way to start with the questionnaire. I hope it was useful. Thank you.
Thank you very much, Noura. Does anyone have a question? Or would like to add any?
Thank you so much. This great presentation. Great info. Thank you.
If there's no other questions, so we can move on to the fourth part of today, which is going to be Dr. Sara Elsayed, a past fellow, sharing her feedback with us today.
Allow me to be a part of today's meeting. It's a true pleasure to join you guys. So congratulations for those who matched. And just in case someone did not match, please don't allow that to hinder you back from like fulfilling your ambition. Just cherish how far you've become and what you've learned so far, and hopefully you get a chance to match next year. Next match, all the best. So quickly giving heads up about my experience with Dr. Nader, which was like a great experience. It helped me a lot, not only in my match process, but also gaining adequate research experience that continues to help me during residency. So I began in May 2021 with Dr. Nader, the Geriatric Research Fellowship, and it was very it was innovative. Like I think it was one of its kind fellowship, being an online research fellowship. From gives me flexible schedule, and also we were very learning all the techniques and the skills necessary to do a research in terms for data collection, data analysis, conducting surveys. We were able to do great presentations in American Medical Associations. We did poster presentations in the American American Society of Cardiology. Also, we were attending like grand rounds at Michigan State University. So all that contributed to not only being part of the medical community and being attached to the medical community, but also being contributing as well to the medical community. Also, during my experience, we had the chance for the match preparation, whether like in case of my situation, like other candidates, other graduates from the fellowship were also like providing insight and tips for the match process. Dr. Nader himself shared his experience with us, which was very insightful and inspiring and encouraging to follow and continue and persisting for applying for that match. Okay, correct, Sharon, clearly? Okay. Is it better now? So overall, it was a great experience. And I actually I've gained so many skills that I can learn, that I continue to carry with me during my residency. So any questions for me?
Thank you so much, Dr. Sarah, and thanks for coming over, and congratulations. So, how is your training going?
So actually, I'm now in second year, internal medicine resident at the North Alabama Medical Center. So I enjoy the everyday growth experience. Like every day I learn something new. Actually, again, like I have, I continue to do research during my residency, and I'll be having like a publication soon to be presented at the ACT in this April in Boston, inshallah.
Congratulations, that's great. So it's gonna be next week, I think, or the week after, the 18th.
Yes, sir.
Congratulations. So I'm very happy for you, and thank you for sharing your experience with us. Any questions for Dr. Sarah? If not, thank you again, and we are always happy to have you. So please keep us posted, and I wish you all the best. A wonderful day.
Okay, thank you so much, Dr. Nader. Thank you for allowing me to be part of today's meeting. And actually, I learned something today also. I was here since how to do like that, how to start an app from scratch. So actually, it's something that I learned as well during today's meeting. Thank you so much for allowing me to join you today.
You're welcome. I'm very glad. Thank you so much. Have a great day.
Thank you, Dr. Nader. Thank you so much. Have a good day. Thank you. Bye.
Any updates? The next item, any updates as far as projects? If you have any new ideas, questions, suggestions. Right, any comments?
Sorry. Hi, I'm new here. My name is Ahma Bara. I just preparing for step 2, and thank you for this opportunity. So I really appreciate it. So I don't know. I'm really interested in research, but I don't know where to start. Like from where. Like I come from Algeria and I rarely had the opportunity to do that in my country. So the first step is where to look, where to start. This is what I want.
Thank you so much, and welcome to the program. So for the new fellows, next week and the week after, we will talk about the process, and you are not the only one who started from scratch with Rahma. So we're gonna build them together. So you build your experience or your skills in this area. So I know some schools back home or overseas, they don't focus on the research part as much. So we're gonna start with the basics and then build on that. So in the coming weeks, we're gonna show you how to do that. So just be patient. The next couple of weeks, we're gonna create teams. So each team will have a team leader. Then during that period, you will have plenty of time to learn. And sometimes we want you to be active. So if you want to actually learn something, you need to do it. Just similar to what Dr. Mafaz was doing today, showing us the basics of how to build a program. So if you really want to learn something about that, you need to go to that website, see what's required, and apply some. Just try it, and if you have questions, go to Dr. Mafaz. Hey, this is difficult for me, or this, I couldn't do this, how do I do it? So the same way, the same concept. So we want you to learn from the basic and go up. It's not difficult, but it needs some dedication, some time. So thank you so much, Dr. Rahma, for this question, and welcome to the program. Any other questions? Any comments or suggestions? So from the seniors, any feedback about the program or anything that you want us to change?
Yes, I just wanted to share. There's nothing that I would change about the program. However, just a quick maybe advice for the next year's applicants. I noticed that during the interview process, there was always something that was interesting about each applicant. So I would just suggest that each person, maybe if you can start learning a language, maybe take up a new hobby that's very interesting to discuss with the seniors and the program directors, the associates. It will make you more seem more approachable and more pleasant to work with, and therefore it will increase your chance of matching, inshallah, soon. That's the only thing that I just wanted to share. Thank you very much.
So thank you so much, Mafaz, for the tip. And yes, it's important to distinguish yourself from other applicants, because you're gonna be competing to be with all these good candidates. So you want to be a little bit different in a sense that you can connect with some of the program, either the program directors themselves or some of the faculty who interviews you. Sometimes you will have some discussion with some of the lessons as well. So if you have hobbies that are unique, or if you want to learn. So my advice is this country has English as a first language and Spanish as a second language. So if you want to, if you have some time, you can learn a little bit of Spanish, maybe medical Spanish. But Mayra, the one presented earlier, she is a Spanish speaker, so it's native speaker. And she started teaching in the past some of the group here, so you can reach out to her and try to learn. So my advice is use some of the mobile app that for languages. And if you say I have no idea in Spanish, I would say you are wrong, because at least every one of you will have the knowledge of 1,000 Spanish words right now, because Spanish and English are similar in some of the concepts or some of the words. So, for example, delicious in English is delicious in Spanish. It's just with a little bit of tweak of the accent, say. So, delicioso or something like that. So, if you know these 1,000 words, you are automatically a beginner in the language. So I would say every one of you should put in the language part, you are learning Spanish, something like that. I know Mafaz was, he speaks German, or he learned the German language. So he distinguished himself when he was applying with the language part as a unique person. So if there is someone from Germany or have visited Germany or they speak, then they will be connected slightly or similarly during the interview. But thank you so much, Dr. Mafaz, for sharing this tip. And you can work on that continuously until the time when it's the interview time. I know some of you from India or some of you from Pakistan. So if you have that language as well, you may have some similarity, some work in Arabic. So try to collect all these and see if you can pronounce them. And then you're going to be an Arabic speaker at the entry level or the basic level. So you will get like astonished or amazed when you look at how many similarities between languages. And you start with the similarities, and then you build on that. It's just an idea. Thank you for raising this point. Any other questions, comments, or suggestions?
Thank you, Dr. Nader. My name is Muhammad Abu Zaid, known by Wadidi, my family name. I'm an emergency physician in Bahrain here. I just finished my step 1 and step 2. I'm applying for the next cycle. Thank you for joining this fellowship. But my question is, there is any curriculum that I have to go so I know more about this fellowship? Like any files or anything, can I read about it more?
So thank you so much and welcome to the program. Thanks for the question. So what we do, we don't have a structured syllabus that we follow, because it's not like the regular fellowship programs that you can join. However, we have some basics that we built on. So, for example, I'm going to just show you the app.
Okay.
So if you go to the app, okay, I'm going to try. I can steal the host from you.
Yeah, in the app, I can see early research experience, middle research experience, late research experience. And there is a lot of available resources down there.
So let's say you are early, you're gonna start off looking at what you need to learn the basics of that. So there are some videos as far as what we want you to know. So let's say about research question. You want to start a project about any kind of research project. You always start with a question of what you want to do, what area, what topic. So this is the most important part. And to do that, there are steps to get the research question in place. One of the important part of that is you want to look at the literature, what's available there. Let's say I want to study about dementia in nursing homes during COVID, something like that in Michigan. So this is my interest. I'm a geriatrician. I work in nursing homes and I see patients with dementia. So this is my question. But to build that question, I need to look at the literature first and see if there is some work in that area with the same or similar question. So if there are people who already answered that question before or raised the question and answered it plenty of time in different directions, then there is no way for me to compete with them because there is no gap in the knowledge there. But if the question is unique and there's no one answer that question or came up with that question, then there is a big room for me to start the project. This is what we call the gap in the research or the literature. So if there is a gap in the literature, then it's easier for you to come up with a question that addresses that gap. If a lot of people spoke about dementia and nursing homes and during COVID, then maybe your gap will be they studied people in the US, but they didn't study people in other places. Let's say Mayra came from the Dominican Republic or somewhere, or you are from Bahrain. So you have the question, but the population is different in your area. So you can use the same concept, same question, and apply it to the population in your place. So it's going to be unique in that you're going to study your population with the same question. So if you want to study patients with dementia or the patients in Bahrain and during COVID, what happened to them, then you can do that. See what I mean? So you can look at the literature and see if there is a gap, that's well and good. If not, you're still interested in the question and people are already there. So you want to modify your question to see what can be modified or changed so that it can be unique. Sometimes you can use the same question, but it's in a different time. So let's say people started talking about a condition with some medication. So in 2004, they started talking about, that's just as an example, Parkinson and the side effects of one of the medication of that used at that time. So you are still interested in Parkinson, you're still interested in that medication, but you can review the literature and you found out that people were talking until 2015, 2016 about these two topics, the disease and the medication. And they did a review during that period. So what you do is you want to come up with the same question, but your period will be different. So we will say a systematic review between 2017 until 2024. So it's going to be the same, but it's covering a different time period. So time, location, these are standard population size or unique population panels. These are ways of modifying your question, if that makes sense.
Can we do this same publication where you did it in USA and we collaborated together in different countries? Like white, the same publication you did it, but we're gonna include, for example, Sudan, Bahrain. We made it wider. Can we do that?
Yes, you can do that. So this is the way to look at it is you want to come up with fun answers in the literature. So you want to add something new to the literature. So if in Sudan or in Bahrain, they didn't do a lot of research in this population about this topic, then it's a good idea for you. It's a very good room to grow in that topic or that population.
Thank you very much.
You're welcome. Thank you. But if you want to look at some of the videos regarding the program, this program, you can go on the right side all the way to the videos or files. You can find some files, you can search them by the topics or some of the videos by the topics, and then you can learn about this. I would advise maybe you can look at, you can search of the videos. In one video Zoom meeting, we had Dr. Raza. He is also a geriatrician, so he was talking about identifier topic for example.
Okay. Thank you very much.
Thank you. You're welcome. Thank you. Any other comments, questions, suggestions?
Nader.
I know we went over. Thank you, Dr. Ahmed. Go ahead. Yes.
Yes. So thank you, Nadir, for touching and answering the previous question, and that talk about gaps. You know, if you look at the evidence in general and research in general, the best is like the trials, clinical trials. But if we look with an examining eye to samples, the populations, the numbers of the individuals studies, the patients and the control group. So they should be representative, okay, like ethnicity-wise, males, females, okay. But if you look especially to the ethnicity, you could argue that all the clinical information has gaps because the representation of the Black population is really very low, especially in this era when medications and when the one-size-fits-all era is gone. For example, if you have a medication, this medication is metabolized at the level of the genes. You have the dogma of DNA, messenger RNA, and then protein. And the protein, that is why it digests. And it will change your medication to the active, for example, metabolite, if the medication is not active from the beginning. Are you with me? So this is different in different population, in white population, in Asian, in African Americans. So nowadays the trial should be people pay attention to the ethnicities, because if you see some medication, especially the immunosuppressants and antibiotics and others, are only more of them are European in origin, for example. This might not be best for people from Africa or from Asia. So the gap is always there. You have to come with a question. And there is no lack of gaps. You can always, but your question should be very clear. And the gaps, as you know, in medical knowledge or in practice. In practice, I mean the clinical. And medical knowledge, it could range from the very basic to translational up to clinical research. Always, when you design your question or your idea or your concept, it is better to discuss that with the whole team, statistician, your other colleagues, and make sure that your idea is very clear or your question is very clear. So you are not gonna reinvent the wheel. You are gonna come up with something novel. So the whole thing about research is things has to be novel, okay? Having said that, yes, you can have a paper on old clinical question, and you can again readdress that issues, because many things will come up, like number of patients, a new medication are emerging, a lot of things. So it is always, you are not wrong when you lead and try to design your research question. It is always better to, this is the area of collaboration. You can do your research in US, in Bahrain, in Sudan, in multiple sites. So, and especially right now, the world is a village. So thank you, Nadir, for addressing the gap. And always look at the population has to be representative. I know you say this is children number is so, but look at the ethnicity as well. And when you see a medication, for example, recommended and dosing, look at this. Is there the population I'm treating, Asian or African or European, are they representative? If not, that might be a reason why your patient is not responding well to this kind of medication. Thank you.
Thank you so much, Dr. Ahmed. And just to highlight what Dr. Ahmed mentioned, for example, when we are that's a long time ago, in the medical school, they taught us beta blocker is no for congestive heart failure. And a few years later, they restudied that, and now they changed that approach. So you can use it, but in certain subset of congestive heart failure. Not everyone is congestive heart failure, especially if they are in acute exacerbation, you don't use it, but otherwise you can use it and it's advised. So this way, you look at things might change over time. So you need to readdress it, look at it again, and maybe you can come up with some new answers or some modifications. To apply that, let's say Dr. Sarah, she just mentioned, she's going to present with her team some poster at the ACP. So if I'm going to show this you here. So the ACP, American College of Physicians, they will have their meeting in Boston in a few days. But last year they presented some, and they have some abstracts there. So this is the list of the abstracts that they presented. And what I can do as a fellow in this program, if I were in your shoes, I'm going to look at these and see what they presented last year, let's say at the residence level or the medical student level or early physician presenter, whatever. So I'm going to just pick this. And this is a list of questions or posters they presented. Sometimes they present as oral presentation or poster, but let's say these are the poster. So this one, if you are interested in kidney problems, you can look at this and see if there is any room for improvement in this area. So you can look at the content and see what they did not cover, and then you start from there, if you know what I'm saying. Or if you want to pick up other disease, let's say like this. This is a national study here in the US, for example. You can apply the same concept of this in somewhere else in UK or wherever you are, like Muhammad in Bahrain, for example. So you try to do something like that, using what's available, recent publications, and then modify them. In my case, I'm looking at the ACP.
Thank you very much. That was informative.
Thank you. Any other questions or comments?
Assalamu alaikum.
Alaikum salam wa rahmatullah.
Hello, and I'm a new participant. I'm preparing for my step 2, and thank you for this opportunity. I just want to ask, you mentioned that we're going to be divided into groups in the coming weeks. I just want to know, are the topics, like, do we come up with the topics we present, or are the topics already set for the presentation? And that's just everything. Thank you.
You're welcome. Thanks. Thank you for the question. So yeah, in the coming days, weeks, you will have your team, and then each team will organize themselves and see who will be available. Like you said, you might not be available because you're preparing for the test, and after the test, you will be available vice versa. Maybe one is available now, the other one may not be available for whatever reason. So the organization of the team is to see who will be available to do what kind of task. As far as the presentations, we divide that into some topics, like this meeting today, different topics, and the team will be responsible for the topics that we suggest. These topics can be solid, like we want you to learn about, but at sometimes we can change them, modify them, or even if you want to suggest us new topics or something urgent that we need to discuss, we can change it. Like when we started this program, it was during COVID, so we were talking about the basic concepts of the research and this and that. And then one of the fellows said, hey, why don't we learn about the COVID itself? So we divide that into small tasks. Someone will talk about COVID epidemiology, one will talk about clinical and so forth. So we modified the topics according to the need of. So this program is for you, and you are the one who decide what you want us to do. So thank you.
Okay, okay, thank you.
Hello.
Hello, go ahead, Dr. Wala.
Hi, my name is Wala Alim. I'm ECFMG certified medical school graduate. I just wanted to say thank you for the opportunity and introduce myself, and looking so forward to be in your teams and do some great research, inshallah. Thank you so much.
Inshallah. Thank you. You're welcome. Thank you. Welcome aboard. Any other questions, comments? Go ahead.
Assalamu alaikum. Hello, Dr. Nadir. My name is Albir, and I recently joined this fellowship program. I just want to say thank you so much for this opportunity. And I want to know, is it a weekly thing, or when do these Zoom calls usually happen?
Yeah, it's a weekly Zoom meeting at 2 o'clock New York time. So the same.
Oh, okay. Okay, thank you so much.
You're welcome.
Sorry, Dr. Nader, you are muted.
No problem. Thank you, Dr. Ahmed. If there are no more questions or suggestion comments, I'd like to thank you all for attending. Thank you, Dr. Ahmed. And I'd like to thank all the presenters for today, Dr. Mafaz and Dr. Mayra. Thank you all. And Ahmed, any
Thank you, Nadir.
comments?
Thank you, everybody.
Thank you.
Great
So
to be with you all.
Thank you.
Assalamu alaikum.
Alaikum salam. Dr. Ahmed.
Yeah, just I wanted to update you regarding the nephrology application. I'm just waiting for my team members to complete their tasks so I can add it to the application. And regarding to the food item list, I already added some items, but I don't know if this is the correct way to go, but I'm planning to add like 50% of the list and then upload the application to the Play Store. And then in the second version, I will be adding the other 150 items that are remaining. So what do you think, Dr. Nader?
No, I think this is a great idea. Usually this is what developers, when they do their app, they will divide into what can be delivered and be applied and be used, and then they can get feedback and then modify, but they have additional features. They don't put all in one version one, if that makes sense. Like the iPhone, when it started, they didn't put all whatever they wanted in that version. They kept some for version 2, version 3. So I have no problem if you want to go with 50 and then version 2, you can work and then see if there's any other modification you want to do, and you add country in whatever list and then see.
Okay, thank you. Yeah, that makes a lot of sense. Thank you so much.
You're welcome. Thank you so much. So I'd like to thank you, Dr. Mafaz, and your team, Dr. Mayra, and the other team members, and the presenters. So we'll see you next week. Thank you. Have a good day or good night, and Eid Mubarak, inshallah. Come with this. So wish you all the best, and thank you, everyone. Assalamu alaikum.
Thank you, Dr. Nadir. Thank you.
Thank you.
Thank you, Dr. Nadir. Eid Mubarak, everyone.
Thank you, Dr. Nadir.
Thank you.
Thank you, Dr. Nadir. Assalamu alaikum.
Thank you, Dr. Nadir. Eid Mubarak. Assalamu alaikum.
Thank you so much. Bye.